Okay, thank you very much for both moderators for the introduction, and it's my honor to kick off this session and talk about coronary CTA pitfalls, tips, and tricks. No disclosures for this talk. I will go straight to tip number one, which is you have to be careful about selecting your patients. That's key for maximizing the value of coronary CTA. Even though our newer scanners can do bigger and bigger patients. This patient here was a BMI of 54, not a good candidate for CTA. This is a second generation SPECT camera that actually got good images. Patients with severe calcium, as our spatial resolution has improved, our ability to accurately diagnose stenosis, even in the presence of calcium, has improved as well. But still, patients that have a massive amount of calcium everywhere, that's going to be problematic. And even though we can now visualize stents, especially larger stents, when you have smaller stents and distal vessels, and some of the newer stents may be more difficult to visualize. So these are folks that you would want to avoid. And in generally, some of these folks, like those with stents or significant calcifications, will be the really high-risk patients. But on the other hand, we may want to avoid CTA in very low-risk individuals, and not just CTA, all imaging in general, and this is just the title of an editorial that will be coming out in JACC in about 2 weeks, where Leslie Shaw and I try to put some construct to the thought of how do we identify the really low-risk patients that don't need any imaging at all to begin with. So now moving on to pitfall number one, which is don't overestimate stenosis. There's many reasons why we sometimes can overestimate stenosis with coronary CTA. And in this particular case here, we see the axial images. And if you look at this and you see on the right side of the screen a image from the proximal LAD, this may appear like a proximal severe stenosis on initial site, but if we actually take these images and walk through them and you follow the lumen carefully proximally, you actually see fairly good lumen. There's an area here that's maybe a little bit more difficult to evaluate, and then the rest of the vessel looks okay. So how are we going to make the diagnosis regarding the severity of stenosis here? Well, one set of planes on the left side of this screen here may be effective at showing you who has or the proximal LAD, showing on these two orthogonal planes here no significant stenosis, maybe mild stenosis. And then on the right side of this screen, further down in the LAD, we also see reasonable lumen, maybe with the exception of this particular point right here, which corresponds to that point right there. And if we look at the short axis images, so kind of the en face view of the vessel, even in the point that's the tightest, which is right around here, there's still reasonable lumen, but our eyes get distracted because there's a lot of plaque around that lumen. So if we really follow the lumen on the short axis images here, even though there's a mild stenosis here in the luminal area, despite a lot of plaque, you may arrive at the fact that this is not a severe stenosis. Obviously easier to realize this if you're in front of your own 3D workstation. This patient did undergo invasive angiography as well, and on invasive angiography, very small amount of plaque is appreciated by invasive angiography. It was mild stenosis. So yes, this patient has a lot of plaque, but only mild stenosis. Tip number two is don't underestimate the significance of a lesion when CTA, but not cath, shows high-risk plaque. So sometimes the cath is not that impressive. And this is an example of a patient that underwent a CTA. And we see actually a large amount of plaque on the left here on the proximal LAD. It's a large amount of plaque right here. But on invasive angiography, when the images were obtained here, the angiographers looked at each other. One of them was my colleagues, and they say, oh, CTA has gotten pretty good, but here's one of those cases where they overestimated the amount of disease. They got this one wrong, but the fellow on the case said, oh, I reviewed the CTA. There was a lot of plaque. We better look more carefully. And they actually did an invasive FFR here. The value was 0.68. So that's a really positive number, 0.68 for invasive FFR. They ended up doing OCT as well to look at this lesion. But essentially, how did we know based on CTA that this was going to be a significant lesion, even though it doesn't look that tight from a stenosis perspective? Well, here's the proximal normal lumen. Here's the area where the maximal plaque is, and in fact, if we look at the plaque, you see this red area right here. This is where, this is all non-calcified plaque. The remodeling index here, which is the diameter of the plaque plus the lumen over the lumen lumen alone, is 2.0. So an abnormal remodeling index is more than 1.2 in many studies, 1.1. This is a remodeling index of 2.0. So this is massive remodeling here. And it has been shown, and here's the distal reference, but it has been shown in this paper and others that when you add these advanced plaque characteristics, such as positive remodeling, such as low attenuation plaque, or just the overall amount of plaque, that adds incremental value at predicting lesions that are hemodynamically significant. So this is a lesion that actually angiographically and even by CTA, mild, perhaps some would call this moderate, but certainly not a very impressive lesion, except for when you notice how much plaque is there. Pitfall number 3. Sometimes things can look worse on invasive angiography than they do on CTA. So here's a 46-year-old female. She gets chest pain once in a while on her 5K runs. Occasionally she goes for a 10K run. And when she undergoes CTA, we see the proximal LAD here on 2 orthogonal views. The first one, no significant stenosis over here. The second one, right at the takeoff of a diagonal branch, we see some non-calcified plaque, perhaps mild stenosis. At most, some would call it moderate stenosis. At the worst location, here's the short axis showing here the lumen, and here's the plaque. And you still have reasonable lumen, so at most, and I showed this case to our fellows and in other conferences, and people would vote whether this is mild or moderate. But no one would call this a severe stenosis. When you now look at the invasive angiogram, this looks really tight. This is what my colleagues in the cath lab would call a 99% stenosis here in the LAD. So very tight LAD. So why is that? Why is there such a discrepancy here? Well, in this particular case, we think this woman had spasm at the time of invasive angiography. Spasm does not happen out of the blue. Spasm happens on top of plaque. And if this woman was living with an LAD that was that tight, she probably would not be able to go on her daily 5 and 10K runs. And this also explains why her chest pain was rather episodic and did not occur with every run. So when you see something tight in the cath lab saying, could this be spasm? The more obvious example is an osteal RCA. Everybody has seen that there's spasm there and you inject nitroglycerin and it goes away. But it can happen in other locations such as here. Tip number 3. There are things that are not plaque that can obstruct the lumen. So what's this one? This is a tough one. If I didn't tell you that this patient actually had an invasive angiogram the day before, and you see this big filling defect. This is much darker and lower attenuation than plaque usually is. This is, in fact, this is black, so that there's this filling defect extending from the left main right here all through the proximal LAD, left main all the way into the proximal LAD. This is a coronary dissection, and I have to tell you, in many thousands of CTAs that I've read, this is the most obvious and most significant coronary dissection I've ever seen. They're usually not this easy to recognize. In fact, the more common view on coronary CTA is such as this one, a 34-year-old female, chest pain postpartum. This is a spontaneous coronary artery dissection where you just see kind of an invasive angiography, just a single line. And on CTA here also, if you get the right plane, you can see a line right through there from the dissection flap. So this is a more typical spontaneous dissection. And on the right here, iatrogenic from the cath. And these are images from the cath just to show you. This patient had an LAD, a lot of plaque in the left main. You can see maybe that the catheter is angled, maybe I would say not ideally. And then when we look at the last shot in this particular image here, let's see if this works. So in this image right here of the left main, I think the most impressive thing here is if I were to pause this and go to the very, very first shot, what you see is a contrast strain before you inject any contrast. So this is an angiography, how we would kind of suspect that this is a dissection. And in fact, when my colleagues in the cath lab saw this, they pulled all the catheters out. They said, we are done. We're not going to put any more catheters in there. oh, let's get a CTA tomorrow to make sure this is looking okay. And one learning point on these dissections that are iatrogenic, they usually travel farther down into the artery. That's the thing we were looking for on CTA. They very rarely propagate back into the aorta. That's always a concern, but if anything, these go downstream into the vessel, not up into the aorta. Okay, so other things that can obstruct the lumen, dissection, we talked about thrombus and mass. This is an example of something that looks like a mass in the proximal left circumflex. However, it's a filling defect, does not have any contrast in it. This is a large thrombus inside an aneurysm. And this gets me to the next point, which is having a large lumen is not always a good thing. We always know that a stenosis is bad, but what if your lumen is just large? Like this patient was Kawasaki disease that develops calcifications on the periphery. They don't have any clots, but having a larger lumen, which can occur from Kawasaki, from vasculitis, from IgG4-mediated vasculitis and many other entities, can be a bad thing. This is an image from a 72-year-old male with atypical chest pain for a month. And what we can see here is a stenosis in the LAD that appears severe. And you see all this low attenuation stuff around the LAD. In fact, if you can't see it, I will show it better in the next view, but here's the RCA as well. And what you can see here in the red lines is the differentiation between this material here inside the vessel and the epicardial fat. In case that doesn't project well, you can see it better here. So this is the right coronary artery here. And in the RCA, you can see slow flow. You can see a very irregular border. But what you might not appreciate on invasive angiography is the tremendous amount of plaque around the vessel here. If we go back to the LAD here, I promised you I would show this better. So here the red lines are actually the differentiation, and everything between these two red lines right here is, what is this? Is this plaque? Is this just a massive amount of non-calcified plaque in the 72-year-old male? Well, maybe, but we saw this on the RCA as well. So what are the chances that there's that much plaque and it's so dilated and it involves both the LAD and the RCA? Well, this is, we think, a very dilated vessel, what we used to call ectasia, but this is beyond even ectasia, that's filled with thrombus. And this is important for the angiographers to know, because when you look at the invasive angiography films here, you appreciate stenosis of the LAD, but you do not appreciate all the plaque that's all the way around this. And the problem is that when you put a stent now in the proximal LAD, the clot kind of go through the struts of the stent, kind of like cheese going through a grater, and go inside your stent, and that's exactly what was observed when a stent was put in. Patient still did okay. He's now a couple months afterwards. But when you have this amount of thrombosis around a vessel, you have to be very careful and know that this is a high-risk intervention. And I have to tell you that my fellows in the cath lab said, well, we often don't know this because if we didn't have the CT beforehand, there's no way we would know that there's all this clot all the way around. Tip number 4, we need to minimize artifacts, and I say whenever possible, because despite our best efforts, sometimes things will happen. This is a woman who has a BMI of 47, and that's okay. We can now get reasonable image quality even with a BMI of 47. But the problem with this scan is that right when it was happening, she yelled out, and I was actually at the scanner in the control room. I was able to hear this. Am I supposed to be feeling all this warm stuff? Of course, the only thing that's worse than someone breathing during a CTA scan is someone yelling during a CTA scan. So that's always a bad thing. And I always say it's our fault. We didn't warn her enough that this was going to happen. I always blame it on us, not on the patients when these things happen. So this is an example of a misregistration, or also known as a stair-step artifact. And there's different etiologies for this, and I think we are seeing this more, at least with some scanners. As the scanners have gotten faster, we may be seeing this even more. Number one is we have to coach our patients on how to be still and hold their breath, and we have to practice that with every patient at the scanner. Number two is, here's the heart rate here. This was a fairly low heart rate. This patient actually got beta blockers. And you notice the heart rate went from 66 to 54 to 57. And the stair step is right here between having a heart rate of 66 and 54. What is the problem? The problem is when you go to a heart rate of 54, the RR interval is much wider. And now you're going to be at a totally different phase in the cardiac cycle. And the trick is that when patients hold their breath, most patients, their heart rate goes down and then it stays down. And if you start imaging as soon as you tell them to hold their breath, the heart rate's still going down, and you started imaging before the heart rate stabilizes. Notice on the right side here, the heart rate is much more stable, 54 to 58. So on your scanner, when you have your breath hold instructions, it's important that there's a little bit of pause. You don't want someone to hold their breath and start scanning right away. You always want a little bit of that pause, and that might eliminate some of these. So why did this happen? This is not a regular breath hold instruction. This was a Spanish-speaking patient, and we turn on the Spanish instructions, and it said, in Spanish, hold your breath, and it starts scanning right away, and this is what happened. Now, let's say you can anticipate this, that someone's not going to do a good job holding their breath, and you say there's going to be a high likelihood of stair-step artifact or misregistration. Maybe the RR interval is very irregular. In that case, I would recommend systolic imaging in reconstructing your images, not as a fixed percentage, but R plus a certain millisecond, for example, 350 milliseconds after the R interval. So perhaps systolic imaging is something that if you plan ahead and you think this might happen. How else can we mitigate this after this happened? We can do some ECG editing. In this particular case, the images were obtained in diastole, but even in diastole, you can do some imaging instead of as a percent of the RR interval. We can, in this case, reconstruct the images 260 milliseconds before the R wave interval. So this is still in diastole, and instead of using a percentage, we're using an absolute. So this may not be relevant to your scan. If you have a scan that scans the whole heart in one heartbeat, which we have one of those too, you're not going to get these misregistration artifacts, but you then have a trade-off that the gantry is so big that the rotation speed may be slower and your temporal resolution may be weaker. So there's trade-offs to all the scanners, and this particular artifact may or may not be relevant to your scanner. So I'm going to end with my last tip, which is tip number 5, and that is that medical therapy works. And this is important, that not all patients with stenosis need to be revascularized. Earlier on in the era of coronary CTA, as a field, we were criticized that coronary CTA, we see stenosis and everybody just goes to the cath lab and they all get stents, and we end up revascularizing a lot more patients than what's called usual care. And this is just an example from one of my own patients, of a patient that on the left here, you can see had a severe stenosis, mostly non-calcified plaque in the left circumflex. And after 2 years of aggressive medical therapy, not just LDL lowering, but also diet and lifestyle changes, dramatic reduction in the amount of plaque to the point that they now just have minimal stenosis on CT angiography. So reducing plaque is a good thing, but this also leads to better outcomes. We have seen this in several registries that have shown that patients with medical therapy tend to have an association with better outcomes. We have had several meta-analyses that have shown that CTA compared to usual care results in a reduction in myocardial infarction. And of course, one of the highlights of this meeting is some data from Scott Hart looking at hard reduction, hard endpoint, a reduction in myocardial infarction and CHD death, showing that use of CTA compared to usual care is associated with a significant reduction in these hard endpoints. So I think this is very strong data, but I want to use this slide to remind everyone that not everybody with disease needs to get a stent or needs to go and have an invasive angiogram, but everyone that does have disease needs to have aggressive medical therapy. With that, I want to remind folks in the audience of 2 upcoming meetings, particularly for those in Europe. We have the SECT winter meeting in Dublin, which will happen in January. And then if you want to kind of hop onto the other side of the pond and come visit us in the U.S. in the summer, in July, SECT 2019, which will be in Baltimore. Thank you very much to all.